So today we are going to do myocardial infarction. It's a serious pathology chapter. So we'll start off by the basic definition. That is, myocardial infarction is commonly referred to as heart attack. It is the death of cardiac muscle due to prolonged ischemia. Roughly 800,000 individuals experience myocardial infarction, and mostly it happens in males are at more higher risk than females. Although like myocardial infarction can occur virtually at any age, it usually occurs in like people from 20 to 40 years of age. Okay. 10% it occurs less than 40 years of age, and 45 occurs people younger than 65 but older than 40 years of age. Okay. Is the most important and feared consequence of coronary artery disease. Many patients may die within the first few hours of the onset. It is incidence is high in developed countries only, and due to a dominant etiological role of coronary atherosclerosis is the reason of acute myocardial infarction. Age, I already told you. Sex, males throughout their life are at significantly higher risk than females, and women during reproductive period have remarkably low incidence of myocardial infarction due to protective influence of estrogen. Okay, women on oral contraceptives have higher chances. Etiopathogenesis, etiological role of severe coronary atherosclerosis. Okay. It is one or more of the three major coronary artery trunks. Like atherosclerosis of one or more of the three major coronary artery trunks in the pathogenesis is responsible for 90% cases of acute myocardial infarction. Myocardial ischemia. Now coming to the three main coronary arteries, that would be your the arteries names are left anterior descending coronary artery LAD, right coronary artery, and left circumflex coronary artery. Anyways, so this is etiopathogenesis. Myocardial ischemia is brought about by one of the reasons: diminished coronary blood flow. Example in coronary artery disease: shock, increased myocardial demand during exercise or emotional stress, hypertrophy of the heart without simultaneous increase of coronary blood flow. Role of platelets: rupture of an atherosclerotic plaque exposes the subendothelial collagen to platelets, which undergo aggregation, activation, and reaction, whatever. This leads to buildup of the platelet mass that can cause an emboly or initiate a thrombosis in the vessel. Okay, basically rupture of atherosclerotic plaque will lead to exposure of subendothelial collagen, which will attract platelets, which will lead to the buildup, and thrombi and emboly will form. Acute plaque rupture. Okay, this is not really important. Anyways, non-atherosclerotic causes are about 10% cases of acute myocardial infarction are caused by non-atherosclerotic factors such as coronary vasospasms, arteritis, coronary ostial stenosis, embolism, thrombotic disease, and etc. Transmural versus subendocardial infarcts. This is not really important. Fuck this shit. Okay. Location of the infarcts. Infarcts are more frequently located on the left ventricle. Right ventricle is less susceptible to infarction due to its thin wall. The region of infarction depends upon the area of obstructed blood flow by one or more of the three coronary arterial trunks. Okay, as I already said, it can be due to those three only: LAD, right coronary artery, and left circumflex artery, coronary artery. Major question asked from this is basically the gross and microscopic changes in the affected organ, that is the heart. Okay, now we have to know this really well. You have to know this very well. Oh God, why is morphology? Okay, now I'm going to tell you how everything goes about. So first I'm going to tell you that nearly all transmural infarcts involve at least a portion of the left ventricle. Okay, they encompass nearly the entire perfusion zone, whatever, and basically, as you know, it occurs due to the occlusion of these three arteries only. Okay, other reasons I have already mentioned, you can mention that. Anyway, so coming to the gross and microscopic appearance of an infarct depends upon the interval of time between the MI and death. Okay, because obviously if you have a myocardial infarction, you're going to die and then only take it out, right, and see what is the changes in heart. So yeah, the gross thing I'm going to explain to you right now. It is damaged myocardium undergoes a progressive sequence of morphological changes involving ischemic coagulative necrosis. Okay, everything will be coagulative necrosis, that will be ischemic coagulative necrosis. Okay, early morphological recognition of acute myocardial infarction can be difficult, particularly when death occurs within only a few hours of the symptom onset. In MIs less than 12 hours, when the myocardial infarction has occurred less than 12 hours old, the changes are not very apparent on gross examination. There is literally no change. However, if the infarct preceded death by at least 2 to 3 hours, okay, it is possible to highlight the area of necrosis. However, if the infarct preceded death like basically what they're talking about is the early infarcts 3 to 6 hours old can be detected by histochemical staining. Okay, by using TTC, that is triphenyl tetrazolium chloride. Okay, this histochemical stain imparts a brick red color, brown red color to intact non-infarcted myocardium. Okay, with preserved lactate dehydrogenase activity, because dehydrogenase leak out through the damaged membranes of dead cells, an infarct appear as an unstained pale zone. So basically, when you are staining it, the uninfarcted region will come to look as red, dark brownish. Okay, and the infarcted place will be pale. Okay, by 12 to 24 hours after infarction, a myocardial infarction can usually be identified grossly as a reddish blue area of discoloration. So basically the infarcted area will be reddish blue in color, discoloration caused by congestion and extravased blood. Okay, in certain books there it is also written, in Hirschmohan it is written about 12 by 12 to 24 hours the infarct region becomes cyanotic, red and bluish color. Okay, you can write the same thing. By 3 to 7 days it is rimmed by a hyperemic zone. The infarct is rimmed by a hyperemic zone of highly vascularized early wound healing granulation tissue. Therefore, thereafter the infarct becomes progressively more sharply defined. So the infarct looks yellowish in color. Okay, yellow tan and soft infarct area. Okay, by 3 to 7 days. Over the succeeding weeks, the injured region evolves to fibrous scar. Okay, You don't have to mention all that, but always you, while writing this answer, you have to mention days up until like 7 to 10 days. Okay. So over the succeeding weeks, the injured region evolves into a fibrous scar. Now histopathological changes, we have to say that histopathological is basically the light microscopy changes. Okay. So the light microscopy changes goes as like this. Typical changes of coagulative necrosis become detectable in the first 4 to 12 hours. Okay. First 4 to 12 hours, so-called wavy fibers result from the contraction of viable myocardium that cause the stretching and buckling of adjacent non-contractile dead fibers. At even earlier time points, there can be subtle changes in nucleus. All this is not required. Histopathological staining, first 4 to 12 hours, you have to say, you can see wavy fibers resulting from contraction of viable myocardium. Okay. First 4 hours or even 4 to 12 hours also you can write that. Wavy fibers resulting from contraction of myocardium, viable myocardium. So basically, firstly, though, you have this thing called the reversible injury time and the irreversible injury time. Reversible injury time is if the myocardial infarction stops within 30 minutes. Okay, 0 to 0.5 hours. Okay, then if it goes on, then it becomes an irreversible sort of an injury, according to Robbins. There's a chart given. Anyways, so we'll go about light microscopy during that time is nothing, but as I said, light microscopy mein, if you see that in the first 6 hours of infarction, okay, you will see however, some investigators have described stretching of the waviness of the myocardial fibers. Usually non-variable waviness of fibers at the border is seen. Then from 0.5 to 4 hours, this is that waviness of fibers at the border. Then 4 to 12 hours, you will see early coagulative necrosis will be obviously there. That is cacheating type of, not cacheating, I think. What sort of coagulative necrosis is seen? Basically, early coagulated necrosis is seen, okay, from 4 to 12 hours, and during this time you can also observe a little bit of edema, like appearance of edema fluid between the myocardial fibers, okay, from 4 to 12 hours. That is, yeah, you will get to see this. Then obviously from 12 to 24 hours, the ongoing coagulative necrosis will be there. There will be nuclear changes like karyolysis, pycnosis and karyorrhexis of nuclei. Then hypereosinophilia will be seen, and early neutrophilic infiltrate will be seen. Okay, this is very important. Then 1 to 3 days, okay, you will see light microscopical changes. You will see coagulative necrosis will be going on with loss of nuclei and striation, and that's it. And infiltrate of neutrophils will always be there, okay, till now. From 3 to 7 days is the where you will see beginning of disintegration of dead myofibers. Okay, disintegration of the myofibers happens. Neutrophils start dying neutrophils. Early phagocytosis of dead cells will be seen by macrophages. Okay, phagocytosis of dead cells will be seen by macrophages. That is, macrophage will infiltrate and phagocytose the dead cells, and you will this is like early granulation tissue will be formed. Then from 7 to 10 days, well developed phagocytosis of dead cells is done and granulation tissue is formed properly at the margins. Then from 10 to 14 days, you will write well-established granulation tissue with new blood vessels and collagen deposition. Okay, now with time collagen deposition will increase and dense collagenous scar will be formed. So this is how you have to write gross feature and the light microscopy feature. This is what I said along with the timeline. Electron microscopy, you have to mention the most important electro microscopy thing is that between the very first hour, okay, like 30 minutes first 30 minutes you will get glycogen loss and mitochondrial swelling. Okay, and for the first 4 hours, 0.30 minutes to 4 hours, you will get sarcolemmal disruption, mitochondrial amorphous densities. Sarcolemmal disruption you have to mention, very important. That's it. This is the whole electron microscopy and light microscopy and gross features of this entire myocardial infarction. So one of the most important things you need to know about myocardial infarction is that firstly I told you about the electron microscopy and all those changes. Chemical and histochemical changes are kind of important maybe. So glycogen depletion in myocardial fibers within the first 30 to 60 minutes. Increase in lactic acid, as I mentioned, loss of potassium from ischemic fibers, increase of sodium in the ischemic fibers, and influx of calcium into the cells, causing irreversible cell injury. Anyways, so diagnosis can be through clinical features such as the pain. Okay, there's sudden crushing prolonged pain in the pericardial location, substernal. Okay, you have to give nitroglycerin during that time. Then systolic blood pressure is below 80 mm Hg and cold clammy limbs happening. Okay, and peripheral cyanosis you can observe. Okay, there's acute pulmonary edema. You can observe that some cases develop severe pulmonary congestion. Basically the person is unable to breathe and everything. Clinical features will always include rapid weak pulse, profuse sweating, diaphoresis, nausea, vomiting, as some to name few. Dyspnea is often due to impaired contractility of the ischemic myocardium, resulting in pulmonary edema and congestion. Anyways, all these are some things. Okay, ECG changes. If you're measuring through ECG changes are one of the most important parameters. Most characteristic ECG changes: ST segment elevation in acute myocardial infarction, that is ST segment elevated myocardial infarction. Other include T wave inversion and appearance of wide Q wave. Okay, there's a wide Q wave and then there is T wave inversion and ST wave elevation. Okay, so that's what I'm saying. This is kind of weird, but ST segment elevation is the most important. Okay, now serum cardiac markers are very important. Okay, these are some of the laboratory diagnoses you have to go for. Okay, laboratory diagnoses include certain proteins and enzymes are released into the blood from necrotic heart muscle after acute myocardial infarction, right? Measurement of their levels in serum is helpful in making a diagnosis and plan management. Okay, rapid assay of some more specific cardiac proteins is available, rendering the estimation of non-specific whatever fuck. Creatine phosphokinase or CKMB. Okay, MB means muscle and brain. This is important. Has three forms: CKMM, CKBB, CKMB. Thus, total creatine phosphokinase estimation lacks specificity. This is a non-specific. Okay. While elevation of CKMB ISO enzyme is considerable specific for myocardial damage, CKMB has also further two forms, so it is not a very good thing, but CKMB and CK elevation overall is a kind of indication. Okay, a ratio of CKMB2 is to CKMB1 is also taken 4 to 6 hours after onset of myocardial infarction. CKMB disappears from blood by 48 hours. You have to remember this. How? Like, probably, I think you have to remember that the CKMB, okay, elevates in the blood like after the onset of acute myocardial infarction, after 4 to 6 hours of onset of myocardial ischemia, this thing is in the blood elevated and then disappears after 2 days. Okay, lactate dehydrogenase, it is again, the total LDH estimation also lacks specificity since this enzyme is present in various tissues beside myocardium. Okay, so has two forms, LDH1 and LDH2. LDH1 is myocardial specific, reasonably helpful in making a diagnosis. LDH levels begin to rise after 24 hours, okay, and reach peak. They reach their peak in 3 to 6 days and return to normal in 14 days. After 14 days, within 14 days. And this is the trend of the LDH, that it begins to rise after 24 hours. Okay, then it is at the peak in 3 to 6 days, and then it begins to go down after by 14th day. Cardiac specific troponins, okay, cardiac troponin T, cardiac troponin 1, okay, these two are very specific for myocardial infarction. Troponins are contractile muscle proteins present in human cardiac and skeletal muscles. Cardiac troponins are specific for myocardium, so are not found in the blood normally, but after myocardial injury their levels rise very high around the same time when CK-MB is elevated. Okay, that is after 4 to 6 hours they are at their peak. Both troponin levels remain high for much longer durations, for 7 to 10 days or 10 to 14 days also. Myoglobin, on the other hand, is the very first cardiac marker to become elevated, and it lacks cardiac specificity and is excreted in the urine rapidly. This is the very first to get elevated and reach the peak, and then within 24 hours it goes away. So basically, myoglobin is the first and the earliest non-specific, rises within the first hour and falls within 24 hours, okay, and it gets excreted by urine. CK-MB, okay, is creatine phosphokinase, if I'm not wrong. It is called creatine phosphokinase, right? Yes, it is highly elevated, rises in the first 4 to 6 hours, okay, after acute myocardial infarction, then disappears from the blood by 48 hours, that is by 2 days. Troponin is, I told you, also rise at the same time as that, 4 to 6 hours, okay. Actually, troponin is very cardiac specific and it is elevated after 4 to 6 hours, same time as CK-MB, and is in the blood till 7 to 10 days or 14 days also. Lactate dehydrogenase is, on the other hand, LDH1 is very cardiac specific, and it is in the blood, like begin to rise after 24 hours, reach their peak in 3 to 6 days, and then return to normal in 14 days. So this is the trend you have to remember for cardiac enzymes. Applications mein you can write pericarditis, cardiac aneurysm, arrhythmia, congestive heart failure, cardiogenic shock, and all this, okay. So this was all about myocardial infarction. That's it.